Hello, Nurse Paige here, and today we are going to be assessing my patient Ryan. We're going to be assessing his eyes, ears, nose, mouth, and his respiratory system. So we're going to go ahead and start with his eyes. So first of all, we're going to check his eyes and make sure they're symmetrical and that everything looks even. So go ahead and look forward for me. All right, and his eyes look symmetrical, so that's good. And then we're going to move on to see if they're entropion or ectropion. And entropion just means that they're inverted, so they're kind of like sinking in, and ectropion means that they're kind of bulging out, so they're like sticking outward. So let's go ahead and assess for that. Okay, and they look good. It doesn't look like they're turned inward or turned outward, so we're gonna go ahead and say that he does not have either of those. And then we're going to move on to ptosis. So ptosis is just a word that means drooping. So we're going to see if his eyelids are drooping or anything like that. So it looks like they're pretty normal. It doesn't look like there's any drooping on his eyes. And then we're going to go ahead and look through his eyebrows, his eyebrow hairs, and his eyelashes, and make sure that there's no foreign creatures or abnormalities, and we're going to check and make sure that it's evenly distributed and the color looks normal and everything. So see, yep, doesn't look like there's anything in there that there shouldn't be. He has nice eyebrows. And then we're going to move on to the sclera, which the sclera is just the white portion of your eye that takes up most of the color. So we just want to make sure that it's not injected, which means red, which could be a sign of inflammation, and just make sure that the color and everything like that is normal and there's no leakage or any fluids coming out. So let's see your scleras. Yeah, and they look really white. They don't look like they're pink or discolored or anything like that, so that's good. We're going to go ahead and move on to the iris, and the iris is the colored part of your eye. So it's the color that surrounds the pupil. So we're going to look at that. All right. They look nice and green, so that's good. I say that every time, don't I? That's good. So then we're going to move to the cornea. So the cornea is the clear portion that covers your entire eye. So if you look from the side, you can kind of see it kind of looks like a clear coating. So we're going to check for clarity and make sure there's no foreign bodies, and it should not be opaque. So if it's opaque, that's bad. So go ahead and look straight ahead. We'll look to the side. Okay. Okay, and the cornea looks good. So then we're going to go to the conjunctiva, which is the pink part of your eye. And you actually have an upper and a lower conjunctiva. It's just like the pink part underneath. So right there. And we just want to make sure it's not like super red or pale or anything like that, and there's nothing in there, no lesions, no foreign bodies. So let's see, I'm gonna go ahead and look at the upper conjunctiva and the lower. All right, and then we're gonna go to the left eye. Okay. Yeah, and it looks pink, so it's normal color, so healthy eye. And then we're going to look at the global tonus, which is the tone of the eyeball. I'm just going to palpate his eyes, and they should be firm. If they're squishy or anything like that, then that's not good. That means something's off. So I'm going to palpate the right eye. It feels firm. Get this eye. All right, everything feels normal there. Okay, and then we're going to move on to the lacrimal gland. The lacrimal gland is where the tear ducts are. So it's like actually right up here. And then below that, underneath right here, is your lacrimal sac. So your tears actually flow all the way around in your eye. So I'm going to palpate his lacrimal gland and make sure that it shouldn't have anything bumpy in there or anything abnormal. It should just feel like an eye bone kind of. Okay. All right. And then I'm gonna palpate his lacrimal sac next, which is right below the eye. So everything looks normal there. And there should be no tenderness, and when I push on it, nothing should be like leaking out, like any like liquid or like pus or anything like that. So that would be a sign of infection. Yeah, so no discharge, no blockage, so his eyes are healthy. And then we're going to move on to the pupillary light reflex. You usually would use an otoscope, but I have a pen light, so that's what I'm going to use for this. And then when we check it with the pen light and we do the pupillary light reflex, I'm going to go ahead and follow the what they call PERLA, and it stands for pupils are equal, round, reactive to light, and accommodation. So, all right. So we're going to check that they're equal first. I'm going to shine the light, and the pupils should get smaller or constrict. Both of them should do it at the same time. Okay. So make sure I'm not pointing. Am I pointing towards me again? Okay. Okay. All right, let me do it again. I'm probably blinding him, but sorry. So that looks good because both of them constrict at the same time, which is what should happen. And they were equal, so both constricted equally, and both of his eyes were equal everywhere. So then next, we're going to do what's called direct and indirect. So direct is when I shine it on one eye, so if I shine it on his right eye, then the right eye should constrict. But indirect is when you shine it on say you shine it on his right eye, and then the left eye constricts. So both of them should respond at the same time. Okay, let me do this again. I'm going to do your left eye this time. Let's see. Okay. And they both, you can't really see from over here, but they both constricted at the same time. So when I shine it on his left eye, his right eye constricted and his left eye. So, and then we're going to move on to accommodation. So I'm going to hold one finger up far away, right in front of him, and I'm going to have him follow my finger towards his nose slowly. So, his eyes, as I get closer, should like come together and cross, and they should constrict. His pupils should. So, look at my finger. Okay. Now follow it. Boop. Okay, and his eyes turned inwards as I got closer, and I watched as his pupils changed in size, and they got smaller. And the reason for that is because when you're further away, you need more light, but when I get closer to him, he needs less light. So that's what causes that. And then we're going to go ahead and go to the extraocular muscle function. So to check for that, we're going to do the corneal light reflex with my pen light again. So I'm going to stand in front of him and shine it. And what this is you're checking for, like, whenever you shine the light, you should be able to see a little like glare or like a little twinkle in his eye, and it should be on exactly in the same spot on both eyes. So it shouldn't deviate, because if it deviates, then that's not good. So I'm going to shine the light and see if I can see the twinkle in both eyes at the same spot. And it was. They were both like right in the center of his pupil on both eyes, so that's good. Okay, and then the next test we're going to do for his eyes is the 6 cardinal positions of gaze. So I'm just going to use my finger, and I'm going to move in 6 different directions, and he's going to follow it. Okay, so look at my finger. So we're going to go here. We're going to go here. Okay, then down. Okay, back up. Now I'm going to go the opposite way. Okay, and he followed that really well. I'm surprised. I feel like I would mess up, but that was good. So, everything's good there. And then we're going to move on and check and make sure that he doesn't have a lazy eye. And the way I'm going to do that is I'm going to cover one of his eyes, and then when I uncover it, it should be pointing towards the same direction as his other eye. If I can see it kind of roll from this side back once I uncover it, then that could be a sign of a lazy eye, and we don't want that. So, all right, so I'm going to start with his right eye. All right, now I'm going to uncover. All right, and his eyes stayed in position. It didn't roll or deviate. All right, next left eye. Okay. All right, so no lazy eye there. Abnormal, yeah, so that would be abnormal if it bounces back. And we went ahead and deferred near vision, so I'm going to move on to distant vision. For this, I'm going to use a Snellen chart. I'm going to have him stand back, and I'm going to ask him once we get there, like, what's the lowest line you can see in each eye. So we're going to go ahead and go out in the hallway because I didn't have room in here. And I'm going to have him do the Snellen chart. I don't know how to flip the camera. Okay, so I made my own chart. It's kind of hard to see because of the color, but that's all I had. And so I hung it up and I did the best I could. This might not be completely accurate because obviously it's not the actual chart. But okay, so I don't know how to flip this. Okay, so go ahead and cover your right eye. Oh no, I'm sorry. First, use both your eyes. So go ahead and look with both your eyes at the chart and tell me what's the lowest line you can see.
The PECFD, I think.
Okay.
It's the fifth one.
So that's above the red line, but that's okay because it's like really light in color. I didn't have a black marker. Okay, now cover your right eye. And then read with your left eye and tell me what's the lowest you can see.
The PECFD.
PEC. Okay, so the same one. Okay, now cover your other eye. Okay, what's the lowest one you can read?
The same one. PECFD.
Okay, so it should be above the red line for good vision, but we're going to make an excuse for this. And he has good eyes. He already went to the eye doctor. So, okay, we're going to go back to the room for the next test. Okay, and this is called the confrontation test. I'm going to stand in front of my patient and have them stare at my nose. And I'm going to put my finger at a 90-degree angle behind each eye, and I'm gonna wiggle it, and this is checking for peripheral vision. So I'm gonna ask him like if he can see it, like what's the furthest, or what's the when he can start seeing it. I mean, so all right, look at my nose. Okay, and tell me when you can see my finger. Can you see it?
No.
Wait, is this 90 degrees? Okay, can you see it now?
If I look that way, yes.
Yeah. Try to look, kind of.
Yeah.
Okay. Now, look at my nose. I don't know if I'm doing this right. Okay, so then, what about now?
No.
Can you see it?
Yeah.
Okay. Okay, so his peripheral vision's good. I'm not exactly sure if that was 90 degrees precisely, but that's what it kind of looked like to me, so I tried my best. So then we're going to go to ears. And we're going to go ahead and assess his ears, and we're going to start off with inspection. So we're going to inspect his external ear and his middle ear. We can't really like get all the way into the internal ear, or the inner ear. So I'm going to go ahead and inspect it. We're going to look at the shape and size. All right, they look even. They look normal size, normal shape. They're not too big, not too small. Oh, let me move this over. And then we're going to make sure, that, like in the last assessment, that his outer corner of his eye comes exactly at the top of his ear, which we already know it's kind of off, but that's okay. So his actually goes like right here, so it's not, if you can see that. So his ears are a little high, but that's okay. And then we're going to move on to his inner ear and middle ear. We're going to make sure there's no swelling, no inflammation, no foreign bodies. So I'm going to start with his right ear. Let's see. Okay. No wax in there. Nice and clean. Alright. And doesn't look like there's any inflammation or swelling. Everything looks normal. So then we're going to do the palpation of his ears. I kind of already touched them, but we're going to go ahead and do that again, and we're going to check the auricle, which is the outer region of the ear, the tragus, which is right here where some people pierce their ears, and then the mastoid process, which is just this bone right directly behind your ear. And I'm going to make sure nothing's tender or anything hurts. So, feel this. Does that feel, can you feel that? Does it hurt at all?
No.
Okay, what about that?
I feel it. It doesn't
Okay,
hurt.
what about this?
Yeah.
Does it hurt?
No.
Okay. Alright, what about this ear? Does it feel?
Feels fine.
Okay. Alright, so everything's good there. And then we're gonna go to hearing. So I'm gonna stand behind him and I'm gonna have him cover his ear on the opposite ear of where I'm standing. Wait, have him cover their ear, opposite ear. So I'm gonna whisper a 2-syllable word and he's gonna tell me what he hears. So I'm gonna do it on this side. Okay, I'm gonna start on the right side. Alright, I'm gonna whisper 2 syllables. Hang on, let me think. Okay. Wait, you need to cover the opposite ear of where I'm standing. Okay.
Do I repeat it?
Yeah.
Tree trunk.
Yeah, I said tree trunk. Okay, now I'm gonna go on this side. Wait, you can't see me. Wait, okay. I'm gonna whisper a 2-syllable word.
Candy.
Yeah, candy. Okay. So he could hear me perfectly fine, so we know that his hearing is really good. And then we're gonna move on to the Weber and the Rennie test. This is also testing for hearing. They usually use a tuning fork, but I didn't have a tuning fork, so I'm gonna use a real fork and pretend like it's a tuning fork. But first we're gonna do the Weber test. So what I'm gonna do is I'm going to pretend like this is a tuning fork. You would strike it on your palm to make it ring, and then you would place it on the top of your patient's head, and you would ask them if they could hear it equally in both ears and if there was equal vibration. So I'm gonna go ahead and strike it. Okay, now do you hear that in both ears?
Yeah. Yeah.
Yes.
Yes.
And does it feel like it's like vibrating on both ears evenly?
Yes.
Okay. Okay, so that was the Weber test. And then we're going to move on to the Rennie test. So the Rennie test is a little bit different. What you would do is you would strike your tuning fork. You can do the palm of your hand or the heel of your hand, or in a video that I watched, you can do your knee as well. But on this one, what you do is you strike it and then you hold it next to your patient's ear and you have them, this is checking for air conduction. So you would ask them if they could hear that and if they could feel the vibration. And then you do that on each ear, and then you would strike it again and you would place the base of the tuning fork on the mastoid process, and you would have them, that would be the next position you would put it. So we're gonna go ahead and do the Rennie test. I'm gonna strike it. Put it next to your ear. Do you hear the ringing?
Yep.
Okay. Yep.
Yes.
Okay. Now I'm gonna do the right ear. I'm gonna do it on the mastoid process. So, okay. Do you feel that vibration?
Mm-hmm.
Do you hear the ringing?
Yes.
Okay. Same on this side?
Yes.
Okay, good. Alright, that was the Rennie. So then we're gonna move on to the otoscope exam. So, what is this? Okay, so pull auricle up and back. The eardrum should be gray and it should be intact, and we're making sure it's not ruptured. So, I'm gonna use my pen light because I don't have an otoscope, and I'm gonna pull his ear up and back and shine my light inside. If it was a kid, you would pull the earlobe down, so it's a little different for adults and kids. But you're checking for the cone of light, and it should be on the right ear. It should be 4 to 5 o'clock, and then you should be when you look on the left ear, it'll be like 7 or 8 o'clock. So I'm gonna start with the right ear. All right, so I'm gonna pull up and back. Shine in there and look for this eardrum. Dang, you got small ear holes. Okay, everything, all the color looks normal in there. Doesn't look like anything's ruptured. Okay, up, back. Wait, go this way. And you don't want to pull too hard and pull their ear off. You just want to do it like just enough so you can see inside. Okay, everything looks good there. It's clean and the color is good. Okay, so we're gonna go ahead and move on to the nose and the mouth. This video is getting a little long, but hopefully it'll load. So the nose, first we're gonna check for symmetry, and we're gonna look inside with our pin light to check and make sure everything's okay. So we're going to be looking at the turbinates, which is part of the mascillary sinuses. I should be able to see the inferior and middle turbinates. Sorry. I'm checking for lesions, redness. Redness would be a sign of inflammation or irritation. And this will be slightly redder than most of the mucous membranes just because there's a lot going on in the nose. So I'm going to look inside. Oh yeah, symmetry. Everything looks symmetrical. It's a little bit slanted, but that's okay. Alright. You got some nose hairs in there to protect your nose. Doesn't look like there's any mucus. It looks like it's like kind of like a pinkish, so that's good. It's not super red or inflamed. And then we're going to move on to the septum. I'm going to check the symmetry, which the septum is just right here. Sometimes people get those like bull rings there. So your septum looks good. It's symmetrical, okay? And then we're going to move on to we're going to go to palpation of the nose. So we want to check for patency bilaterally. And so I'm going to have him take a deep breath through his nose, and we want to make sure that the air is coming in equally on both sides. Okay, take a deep breath. Okay, then let out. Okay. And then I'm going to block off each nostril separately, and I'm going to have him breathe again. It should be patent, meaning he can take a deep breath. So we're going to start on the right nostril. I'm going to cover it up, and I'm going to have you take a deep breath in. Okay, now out. Okay. I'm going to take a deep breath in. Breathe. Okay, and both his nostrils are clear, so he's not stopped up on either side. That could be a sign of like a cold or allergies or something else. So did that, okay. Now we're going to palpate his sinuses. So you have your frontal sinuses, so we're going to do those, and then you have your maxillary, wait, hang on a second. And you have your maxillary sinuses, which are below, which are like right here. So we're going to start with palpating, which I'm going to take my right middle finger and place it on his frontal sinuses, and then I'm going to tap it with my pointer finger. So, and I'm going to do it on both sides of his forehead. We'll start on the right side and palpate, or percuss, I mean. Oh, wait, wrong finger, I'm sorry. Pointer finger on middle finger. Okay. Alright, and was there any tenderness whenever I did that?
No.
No tenderness? Okay, that's good. That means that his sinuses aren't, that his sinuses are healthy. So I percuss that. Now I'm going to percuss his maxillary sinuses, which are under his eyes. I'm going to palpate on both sides and ask if he has any tenderness. Any tenderness there? Any tenderness? Okay, we're good there too. Then we're going to go ahead and defer the illumination of sinuses, but what it would be is you're just putting a light in the nose to check for the frontal sinuses, and then you're putting a light in the mouth to check the maxillary sinuses, but we're going to go ahead and skip that. And And then we're going to also defer the cranial nerve 1, which is the olfactory nerve. That's just your sense of smell, which you would normally hold something up and they would smell it like a rubbing alcohol cloth or something like that, but we're not going to do that. So we're going to move on to the mouth, and we're going to start with inspection. I'm going to inspect his lips, make sure they're not cracked, dry, they're not swollen, that they're normal in color and symmetry. So let me see your lips. They look normal. They don't look dry, they don't look swollen, they just look like healthy lips. Okay, then your teeth. So go ahead and open your mouth and look at your teeth. And you want to make sure there's not missing teeth, like they're not like super like yellow, black, any of that. So okay, and all his teeth look good. And then I'm going to use a tongue depressor. Oh, I need to use a tongue depressor to look at your teeth. I'm so sorry. Okay. So open your mouth. Okay. That way you can get a good look inside and their tongue isn't in the way hiding any of their teeth. And then we're going to look at the gums, make sure they're not pale or red. They should be pink in color. Otherwise, something could be wrong with their gums. So go ahead and open your mouth again. Okay, smile. Okay. All right, his gums are pink, so they look normal in color. Then we're going to move on to the mucosa of the mouth. We're going to look at his hard and soft palate. Sometimes there can be a normal variant instead of an abnormal variant. The normal one would be something like a bony torus, which is like what you said you had, Professor Randall. I don't believe I do have that, and I don't think he does either, but we can go ahead and check and see. So I'm going to look at his palate, hard and soft. So open your mouth. All right. And it looks normal. It looks like everything is good in color, pink. There's no bony torus or anything like that. And then we're going to move on to the motor nerve, cranial nerve 12, which is the movement of which makes your tongue move. So I'm going to have him stick his tongue out and check for tremors and check for his muscle strength in his tongue. So go ahead and stick your tongue out. Okay, now can you move it side to side? It looks like you have like a hole right there. Okay. And then I'm going to use this tongue depressor, and I'm going to have him press against each side with his tongue to make sure the muscle strength is good. So go ahead and push against the tongue depressor. Should be able to move it. Okay, now this one. Okay, because the tongue is strong, so that's good. And then we're going to check cranial nerve 9 and 10, which is the uvula check. I'm going to have him say "aw," and I'm going to look inside his mouth, and the uvula should rise, and it should move like up. So, okay, let me look. Say "aw."
Aw.
Wait, let me hold your tongue down. I can't see your uvula.
Aw.
Okay, yep. Whenever he said "aw," his uvula went like straight up. Then we're going to look at his tonsils. So it's a scale between a 1 and a 4 to see his tonsils. So like if it's a 4, that means his tonsils are basically touching, and that's the worst you can get. If they got their tonsils removed, it'd be a 0, and a 1 and a 2 is pretty normal. But once it gets up there to 3 and 4, that's when they're like swollen, and that means something's wrong, like maybe they have strep throat or bacteria infection. So I'm gonna look at your tonsils. Push your tongue down. We're gonna need 2 utensils for this one. Okay. I can't see him. Oh, I see him. Okay, I'm gonna give him a 2. Wait, maybe a 1. Let me see. No, actually, I'm just gonna give him a 1 because his tonsils are pretty far apart. Okay, so that's all we're gonna do for the mouth. Now we're going to move on to the respiratory assessment. So first we're going to check his anterior chest, which is the front of his chest. We're going to look for shape and symmetry. So I'm going to have him take off his shirt for this assessment. Okay. Okay, so let's see. Looks pretty symmetrical. Okay. And so we're going to look at, it's called anterior posterior, which is the size and the width of your chest. It should be twice as wide as it is deep. So twice as wide, so 2 hands here, and it should be like only like 1 hand here. So I'm going to go ahead and do that. So 2 hands here. Well, it's like 1, 2, wait, raise your arms. Yeah, so he's like 2 hands in width and 4 hands in, in width, he's 4 hands and 2 in depth. And then we're going to be checking for respiratory distress. So we're going to make sure that when he's breathing, there's no like accessory organs being used, or his nostrils aren't flaring, he's not pale, he's not sweaty, anything like that. So take a deep breath for me. Okay, and everything looks normal in the anterior. It doesn't look like he's in distress when he's trying to breathe. So I'm going to go ahead and palpate his anterior chest and check for tenderness, lesions, nodules, anything like that. So you want to go in like this kind of a pattern when you're doing it. Okay. I forgot. Am I palpating like... Okay. So I'm going to use the ulnar surface of my hand when I'm doing this. So... that's right. Okay. Have patient say 99. Okay, so I'm gonna redo that and have him say 99, and I should be able to feel a dull vibration. And I'm gonna place my hand in 6 to 8 places. So let's start over. Okay. Say 99.
99. 99. 99. 99. 99. 99.
Okay, and that was 6, and I could feel the dual vibration when he said 99. Abnormal would be if there was like an increased vibration or there was no vibration at all, then that wouldn't be an abnormal finding for his respiratory breathing. So then we're going to move on to percussing his anterior chest. So again, I'm going to use my middle finger and I'm going to percuss with my pointer finger. I'm going to tap. So I'm going to strike it in 10 to 12 places, and I'm going to move in that same pattern. So wait. Okay, and everything seems normal there. Was there any tenderness when I did that?
No.
Okay, good. And then I'm going to auscultate. So I'm going to use my stethoscope, and we're going to start with the tip of the lungs, which is I think I'm saying this correctly, apices of the lungs above the clavicle. And I'm going to listen for bronchial sounds at the top, which can be found, your trachea produces your bronchial sounds. So I'm going to go ahead and listen. Okay, so okay, everything sounds good there. And then we're going to move on to the broncho-vesicular sounds. Those are like where the bronchus attaches to the lung, so it's a little bit lower than the bronchial sounds. It's in the first and second intercostal space, close to the sternum where the bronchus separates. So your sternum's right here. So I'm going to listen for that. Might need to put these in. Okay. And I'm going to use the diaphragm of the stethoscope when I'm listening. Okay, so everything sounds good there. It should be like a dull sound. I kind of heard his heartbeat a little bit. So then we're going to be, and then if you wanted to listen for the vesicular sounds, those are within the whole entire lung cavity, so that could be anywhere on the chest. So I guess I can go ahead and do that as well and just listen anywhere on the chest for the vesicular sounds. Take a deep breath. Okay. So, the bronchial sounds should have been harsh and loud, which I could hear those more at the top, on the neck. I'm going to go ahead and check and see if I can hear harsh and loud on the neck on both sides. Yeah, those were a little bit more loud than the rest of the ones I listened to. So I had him take a deep breath. Oh, I didn't ask you to take a deep breath, but you did. He took a deep breath. And then we're going to move to the bronchiovesicular sounds. And I'm going to go in, I'm going to listen, and I'm going to go in this motion like I did before. So... okay. I think I just did this, but I don't know what I did. Okay. Okay, and again, the vesicular sound would be across the entire lung space, so that could be anywhere on the anterior chest. So then we're going to look at the back of the chest, and that should also be 2 to 1 in width and depth. It should be 2 on the width and compared to 1 on the depth. So, okay, so I'm going to have you turn around so I can check the back. So just sit on the edge of the bed. Okay. Okay, so go ahead and take a deep breath for me. Did you take a deep breath? Wait,
Yes.
do it one more time. Okay, and that's good. No accessory organs were being used, and everything looked normal, and when he breathed, both sides went up at the same time. So it was symmetrical. So I'm going to go ahead and palpate, and I'm going to check and see if there's any tenderness and make sure there's no nodules or abnormalities. Okay, so I'm going to use the ulnar surface of my hand again. I'm going to do what's called tactile firmitis. I'm going to do 8 to 10 places and have him say 99. Okay, say 99.
99. 99. 99.
Okay, and I should be able to feel like a dull vibration when he's saying 99. And so now I'm going to percuss. So I'm going to use in 14 to 18 places, I'm going to use my middle finger on my right hand, and then I'm going to percuss using tapping it with my pointer finger on my left. So I'm going to strike. Okay. Okay, so then we're going to move on to auscultation. So I'm going to listen to the back just like I did on the anterior chest. I'm going to listen the same way. So at the top of the back, I'm going to be listening for the bronchiovesicular. And I think on the front I had said, wait. Okay, yeah, because we can't really hear the bronchial sounds because those are like right up here, and on your back it's really hard for you to hear that. So we're just going to do the bronchiovesicular and the vesicular. So on the top of the back. Okay. Take a deep breath for me. Okay, and I could hear those sounds. They sound good. And then we're going to move on to vesicular, which would be the entire lung span, so you can pretty much listen anywhere on the back. So take a deep breath for me. Okay, take a deep breath for me. Okay, I'm just going to have him do it twice because he's been taking a lot of deep breaths. So then we're going to move on to the voice sounds by auscultating. The first sound that you could hear, this is one of three. It's called bronchophony. Bronchophony is when you listen anywhere over the lung field and have them say 99, and it should be muffled when I'm listening. So, let's see. Okay. Okay. So, I'm going to have you say 99.
99.
Okay. Say it again.
99.
Okay, and it was muffled. And then there's the other two that you can do whenever you're auscultating someone's lungs. You can do one that's called egophony. I'm pretty sure that's how you say it. And that's anywhere on the chest as well. But you have them say the letter E. And when you listen into your stethoscope, it should translate and sound like aw. It's not really what they're saying, but it should sound that way through your stethoscope while you're listening. And then the third one is whisper pectoriliquy, and that's where like you'll have them whisper 1, 2, 3. So you can test their lungs for that as well. And I believe that's it. That was the whole assessment on the eyes, ears, nose, mouth, and respiratory system. So thank you so much. Bye.